welcome to what is actually the 17th meeting of the West Yorkshire Health and Care Partnership Board. So that means we've been meeting in this format for more than 4 years now. Today's agenda includes our regular update report from the Partnership Chief Executive, Rob Webster, an item on dentistry and oral health in West Yorkshire, an update on progress against the West Yorkshire Partnership's Tackling Health Inequalities for Black, Asian and Minority Ethnic Communities and Colleagues review, and a linked report on data insights on race equality across the partnership, a report on partnership working between ourselves and the Combined Authority, and a paper on developing the role of this partnership board based on the informal development session we had last time. I started by introducing myself and saying my name is Tim Swift. I'm the chair of the partnership board and now deputy leader of Calderdale Council. We have a short comfort break scheduled slightly earlier in the meeting than we've done it sometimes, so hopefully that will work a little bit better. And as always, I know we're all very used to online meetings by now, but if I could remind people to mute the cameras when you're not presenting or speaking, but please, mute your microphones. But when you are speaking, please have your cameras on. And if you want to comment at any time, please use the raise hands function or the chat function to let me know that you want to contribute. Just before we start, there's a few changes and updates I just wanted to share with people. Calderdale Cares Partnership, one of the 5 locality partnerships, we've just appointed Joe Bibby to the role of independent chair, taking over on the 1st of June from John Malaloo. Joe's the Director of Health at the Health Foundation, responsible for leading the Foundation's Healthy Lives strategy. She's also led on areas such as health inequalities, patient safety and person-centred care. She's also a trustee of Centre for Homelessness Impact and has a decade of experience as a non-executive director in the NHS. Secondly, congratulations to Fatima Khan Shah, who started in her new role as West Yorkshire Inclusivity Champion last month. This is a combined role between the ICB and the Combined Authority, so Fatima will also be working closely with the West Yorkshire Mayor, Tracy Brabin, as well as the Chair of the ICB, Kathy. Martin Havenhand has just appointed as the new Chair of West Yorkshire Ambulance Service from the 1st of April. Martin succeeds Catherine Lavery, whose term of office came to an end in November 2022. And also a welcome to the system to Peter Redding, who's been appointed as the Interim Chief Executive of Yorkshire Ambulance Service from the 1st of June, joining from the North Lincolnshire and Goole NHS Trust. And perhaps we can extend our thanks to Rob Barnes, who stepped down from the Trust at the end of May 2023. As I mentioned, also, I've changed role myself in that I've now stepped down as leader of Calderdale Council, but I'm continuing as deputy leader, and leaders and health and wellbeing chairs will be discussing and confirming what they want to do about the ongoing chair of this partnership at a meeting later in the month. So we'll keep people updated on that. Item 2 on the agenda, questions and deputations. Unusually, we don't have any questions or deputations today. They are one of the opportunities we offer for people to contribute to the meeting. It's quite unusual. I think this might be the first meeting where we've not had any questions at all, but hopefully we will in the future. Item 3, declarations of interest. Sorry, Ian, do you want to comment?
Yes, thanks, Councillor Swift. Ian Holmes, Director of Strategy and Partnerships for the ICB. Just to say, we received one question, but it was a specific issue relating to a general practice in Bradford. So we're going to deal with that in writing because it didn't relate to the agenda item today, and Bradford colleagues will reply back. So just so the member of public who wrote to us is aware that that's how we're dealing with that one. Thank you.
Oh, thanks very much, Ian. Sorry, I was moving on a little too quickly. So item 3, declarations of interest. Just to remind everybody that, of course, we do take any conflicts of interest very seriously, and our responsibility to be transparent about them. We all have registers of interests in our own organisations, which record those interests. But if there is anything specific relevant to items on the meeting people feel they should declare, then I'd urge you to do so either now or probably more appropriately when we get to that specific item. So that brings us then on to item 4, which is the minutes of the last meeting. These have been circulated. And can I just check, first of all, for any indications if anyone has any points of accuracy or comment on the minutes? Okay, that's great. Not seeing any of that. So I'll hand over to Ian then and ask Ian if you could update us on the action log.
Yes, thanks, Councillor Swift. So I think there was 3 actions that we hadn't closed. The first one was for James Thomas, and it related to a particular conversation at the clinical forum around the diabetes recovery project. That actually happened in the April clinical forum. James, do you want to give a quick update on that? I see your hand's gone up.
Yeah, no, thanks, Ian. Yeah, so I can confirm that so this came about following a board discussion end of last year, and Dr. Stephen Cleasby brought it up in terms of understanding the impact that the diabetes recovery programme that took place in Caldervale, using non-recurrent funding, some of the learning that came from that, from a relatively small amount of funding, but some significant impact both on individual and personalised care, but also in terms of some of the outcome data from the cohort, which was around our community in patients and learning disabilities and serious mental illness in Caldervale. So that was taken to the Clinical and Care Professional Forum at West Yorkshire, and we had a good update and good discussion. And I suppose the challenge was not only in terms of specifically around diabetes, but how do we understand some of the learning that's applicable not to the diabetes recovery programme that was highlighted, but to other elements of care. So this is shared with the clinical and care professional leaders to take into their various forums across our places to kind of look at how some of that learning could be taken in, working with kind of individuals in various communities, what was a small amount of funding there. So it has been completed, and I'd hope that you'd start to see some of that learning and sharing happening across our places as we go forward. So thanks, Ian.
Thanks, James. The next one was a governance issue, really, which was around agreeing of the terms of reference of the ICP, so this partnership board with local authorities. Laura, do you want to provide a brief update on that?
Thank you. Yes, so it has been, the terms of reference have been signed off by the ICB, and I've followed up in respect of local authority sign off this morning. We're just confirming the formal requirements for that, and I'm hoping to have that resolved by the end of this month.
Thanks, Laura. Then the third action followed the conversation in March on the West Yorkshire strategy, and it was around sort of the growing the workforce, our ambitions around terms and conditions. And Kate, I think you've got an update on that one.
No, thank you, Ian. I mean, just for those who weren't there, the context of this is we were asked, I think, the challenge was set across the partnership board about whether we were being ambitious enough in relation to potentially some of the disparities of terms and conditions, particularly around starting salaries. So although the action reads quite broadly, I think the focus was more in relation to starting salaries around real living and national living wages. I was asked to speak to the people board about that, which we duly did at the last meeting, and I put a proposal together that we are establishing a very short task and finish group. I think the membership is predominantly around the VCSE, the voluntary sector, certainly some of our colleagues in the hospices, and also from a local authority point of view. So I have a couple of colleagues who are working with me on just making sure we've got the right scope. And I think the task of that group will have 2 things. Firstly, to do some benchmarking to really sense check where we are in terms of entry level salaries, accepting that has the knock-on implications. But I think in terms of then understanding any implications of if we were to propose any elevation of those. And my intention, Chair, is at this September meeting of the Partnership Board that we will bring a summary paper back of that work. And I think this is where the conversation then needs to take place. But that work is underway from that perspective. Thank you.
And that's it. Thanks, Councillor Swift, in terms of the actions.
Thanks very much, Ian. Can I just check again, any questions or queries on any of those actions? Okay, thank you, Ian, and thank you, colleagues, for those updates. So, item 5 is update from our Partnership Chief Executive Lead, Rob Webster, and I'll hand over to Rob.
Thanks, Chair. Hello, everybody. My name's Rob. I'm the Chief Exec of the Integrated Care Board and the lead Chief Executive for the Integrated Care System. It's good to see you all today. You've got the report in front of you, and there's a more detailed report that was taken to the board of the Integrated Care Board. Apologies for the nomenclature. It's nationally designed, isn't it, to call an organisation a board, unfortunately. But you know what I mean. So you have 2 reports in front of you from me and some briefings. I just want to draw out a few key points. So the first is that I have written to everybody in the partnership, and hopefully that's been cascaded to staff, to say thank you for the huge amount of work that's gone into dealing with COVID-19. That's because the World Health Organization have declared the global pandemic over, and the state level 3 regional incident has been stood down as well by NHS England. So we're now in a living with COVID phase, and I thought it was helpful for us to mark at that point the huge amount of work that's gone on, which will continue to feed into the lessons from which will continue to feed into COVID inquiry. At this point, I'd also like to continue to encourage all organisations and leaders around the vaccination programme. As we continue to live with COVID, we need to ensure that those at risk are being vaccinated. As you can see from the paper, we're doing comparatively well with the latest cohort, with over 70% of people vaccinated who we've been targeting. So that's the first thing I want you to emphasise, and thank you to the Yorkshire Post as well for publishing the letter alongside the internal cascades. Second thing that's on our minds in this context of living with COVID and moving into a new set of arrangements is industrial action. And you can see that the Junior Doctors Committee of the British Medical Association has notified us of an intention to strike over 3 days in next week. And as with the other strikes, we have been and will plan for and support organisations and the system to ensure that safety is paramount and that disruption is minimised. There will be disruption. There'll be disruption to planned care, and there'll be disruption to people and citizens. So our hope is that the government and the British Medical Association will rebegin talks soon, so that industrial action by junior doctors can be concluded. There are, expectations that there may be further industrial action from other groups of doctors as the consultants and the SAS doctors are engaging on whether to take industrial action. We know that the Royal College of Nursing is also balloting members on further industrial action. As you can see from the papers, we are currently looking at the Agenda for Change offer, which was accepted by the Staff Council on a majority. So any further industrial action by individual unions will be in that context. So we continue to plan for and live with that. And I think the thing I'd want to reinforce for all leaders in this conversation is the amount of work that goes in, you all know this, the amount of work that goes into managing the consequences and the direct impact on our staff, whether they're striking or not, is substantial. Having to reorganise things, reprioritise things, apologise to patients and the public is wearing. And we need to, in a compassionate and kind culture, recognise that for all of our staff. The third thing I wanted to emphasise is that, we are now in a new financial year, and we shouldn't let the previous financial year pass without recognising the substantial progress that was made despite all of the pressures that we faced. And if you want to pick on something like money, we delivered our financial targets right across the system in what was a very complicated set of arrangements throughout the year. So thank you to everybody for that, and thank you to all of the finance teams for supporting organisations to deliver that. And we made substantial progress on elements of performance. So despite all of the industrial action, despite all of the impact of winter, we reduced 78-week waiters by 94%. And we all but eliminated 104-week waiters and continued to make progress on things like cancer, where we did comparatively well compared to others. And we've seen recent improvements in things like Yorkshire Ambulance Service performance. So it was the end of the year. We did have a meeting with the senior leadership team from NHS England to talk about our progress and our position. That went well. We had a good conversation, and we talked through some of the things that we need support on, as well as some of the areas where we've made progress. At that meeting, we talked about plans for this year, and those plans have been signed off. They include a significant amount of risk. There's nothing new there, is there, for us? As set out in the board assurance framework and the risk register for the Integrated Care Board, for the assurance frameworks and risk arrangements for every place and organisation, we know we carry substantial risk. And what we're trying to do is to make sure that we manage that across the year. But we have signed off our plans. We have unlocked some additional support financially from the centre, about another £32 million on the back of that, which helps. But we're under no illusion that significant risks remain. Some of those risks that we've been aware of have been ameliorated very recently, and you'll see in the paper that there are references to Airedale Hospital. I know I can see Andrew Gold on the call, and been with Faluki this morning. Everybody in the Bradford District and Craven and the Airedale system will be delighted that the Airedale Hospital is now part of the new hospitals programme, and that we've been promised resources to deal with what is one of our substantial risks. It's a risk with a score of 20 to 25 on our risk register in the system, and it's something that we can now deal with and address. It's also great to see the commitment to the 2 new hospitals in Leeds, and we are continuing to make progress on some of the areas of capital development. So I just wanted to draw some of those things out about the end of last year going into this year, and good news on areas like major capital schemes. We continue to have conversations with the centre around some of the other capital requirements, and getting Airedale over the line, getting our YPFT's 5-year time horizon sorted, and ensuring that Linfield Mount continues to be in our plans for the future. The final thing I'll say is we're doing all this in the context of a review of our operating model. We benefit, don't we, I think this partnership board has been meeting for 4 years and does so in public and sets the strategy for our system. We have strong places, we have good providers, and we have strong provider collaboratives. System, place, provider collaborative is good. We have to make a 30% running cost reduction in our Integrated Care Board, and we are taking that as an opportunity to review the operating model. We know that as you implement your arrangements, which we have with new statutory bodies, it's possible and likely that you won't get it right first time, that there will be some duplication of effort, there'll be some slight confusion over things every now and again. And we're taking this reduction in running costs as an opportunity to have a look at the operating model, make sure it's right, make sure it's clear, make sure we are reducing costs, because we have to make efficiencies anyway, given the financial position we find ourselves in, and making sure that what happens at system, what happens in place, and what's delegated to providers is planned for and is delivered. And we're at a good point in that process, thanks to the engagement of everybody. And what I would point to is we continue to make significant and sound progress at system level. So I can see Jen Connolly on the screen. We've talked about Fatima. We've got these joint appointments with the combined authority, close working with the mayor around what are we doing on wider determinants and inequalities. If I look at our places, we just heard about the appointment of Joe Bibby's great appointment to Calderdale, but we can also point to the corporate peer challenge that's just been published in Calderdale, which talks to the ambition of that place, the good arrangements in that place, their contribution to this partnership and to the combined authority, and to ensuring that their strengths on things like culture play out in the work that we do. And just this morning, I was with Wyatt colleagues, the chief executives, talking to the next cohort of leaders about how Wyatt, the West Yorkshire Association of Acute Trusts, continues to be a strong collaborative that drives improvements for patients and populations with that lens of inequality. So I think that we're well placed because of the work that we've done together over the last 7 years now, to move into the future with a good operating model that tries to deliver in what is a pretty challenging environment. So I hope that's helpful, and happy to take any questions.
Thank you very much, Rob. I'm sure it is. So I'll open this up to questions, and can I bring in Councillor Viv Kendrick first?
Thank you very much, Tim. Thank you for that, Rob. Always informative as usual. Thank you. I'm just really interested in 2.7 on the annex. I mean, it's comforting to see that local efforts are continuing to improve access for people and supporting staff. But the comment above that, awaiting the publication of the National Primary Care Improvement Plan and the NHS Long-Term Workforce Plan, I just wonder that, I mean, for me, these must be key documents, the foundation stones for us improving access for people to services. Is there any indication of timescale around that? Are they just awaiting publication, or are they somewhere in the midst of time?
So thank you, Councillor Kendrick. The Primary Care Access Plan has now been published, and we're working through the delivery of that, and happy for Carol McKenna, our colleague Ian, to give you an update on how that's progressing. In terms of the workforce plan, I think it was yesterday or Friday, the NHS Confederation and a range of national bodies wrote to NHS England and the government asking them to accelerate the publication of the workforce plan. So the workforce plan, as I understand it, has been written. The analysis has been done. It exists. It's built on a lot of engagement with people about how many people we might need, what sort of training, but also what sort of culture and what sort of support we give to retain people. It's I think it's stuck in ministerial and treasury sign-off at the moment.
Thank you for that. Let's hope it's published shortly.
Thanks very much, Rob. So was it Ian or Carol? Did either want to comment briefly on the primary care access plan? Yes, Ian. Yeah.
Yeah, thanks, Councillor. I'm happy to come in first. Carol might want to come in after. Yeah, so I think it was published about a month ago. It felt like quite an operational sort of plan, really, and there wasn't a huge amount of stuff in there that was new. A lot of it was around how you deal with the sort of the 8 AM surge on a Monday morning, how you use digital technology to improve access to appointments, and the way that we're managing that at West Yorkshire level through the ICB is through our fuller delivery board, which includes representatives from each place, plus clinical and professional representatives. The next step for that is that there's an expectation that we take our response to that plan to our board in September, so the board of the ICB in September. So we'll be taking it back there for approval through the ICB route.
Thank you. Carol, would you like to add to that?
Yeah, just to add to that, from a Kirklees perspective, Councillor Kendrick, we're intending to have a more detailed discussion on general practice and primary care in our place committee in July, which I know you attend, so we can pick up some of the local nuances there.
Thank you. Thanks very much. Your health colleagues will understand that for many of us in local government as local councillors, access to primary care is a real challenging issue that we hear a lot about from our residents. Of course, we want to strike the right balance between reflecting their concerns, but also helping them to understand the huge pressures and challenges that primary care is facing. Kathy.
Thank you, Tim. I suppose just on reflecting on that, we're finding our way at the moment, aren't we, in terms of the ICB board meeting on oversight and performance across the system, and then bringing key topics that for our partnership linked to our strategy, and also the insight that Health Watch is giving us. So the dentistry topic today is one example, and as Ian said, the work on primary care through the Fuller Delivery Board will come in September, and I wonder, Tim, whether we then might link that back in to come into a partnership board either in September and December, so that particularly is helpful for elected officials. That wasn't the point I was going to make. I wondered if Rob might comment on the Hewitt review, because there may be an instinct to respond as a system, but it's not quite the right time yet. So I know Rob's got his hand up to come back in, but I wondered if perhaps colleagues might want to hear more on the Hewitt review.
Thanks, Kathy. Yeah, Rob.
Sure. I mean, I think on the primary care point, all places are getting on with it, I think would be the first thing I'd say. As Ian said, the primary care access recovery plan includes some important things in it, including the links between primary care and hospitals, our GPs and hospitals, and making those clearer and better. And it includes some important things that could help the infrastructure around telephony, etc. And what we should all, I think, advocate for, I hope, is that our general practices in West Yorkshire are doing substantially more activity now than they were prior to the pandemic, that they are doing that in a way which 70% plus of contacts are face-to-face, and around half are on the day, and there's just a supply and demand mismatch at this point, which is why we need to ensure that, you know, part of the infrastructure changes are about making it easy for people to get through, so there aren't multiple calls coming through. Part of the role that we have to have through the Fuller work is say, well, what's the response to people's needs? And it doesn't always have to be a GP, and it might be better if it's somebody else. And the expansion of roles that we've got in primary care around pharmacy, physio, etc., is such that there will be alternatives for people. So as we go through this period, I think I just wanted to get the partnership boards understanding that we're not waiting for July or September in terms of when we're reporting back. Places are actively getting on with their general practices and community partners, the third sector and others, in improving people's access to care. And it is a priority for everybody. It's a priority for everybody to get this right. I can talk about the Hewitt review in a minute, but I didn't know if Linda was coming back on the primary care point. I think she might be.
Yeah.
Actually, as you know, I do think a lot about primary care, but it's actually really about the broader workforce issue. And I think there's something which I hope will come out in maybe the ability of the ICB and Partnership Board talking nationally about distribution of workforce, because it's all very well, we might get another 1,000 doctors or another 1,500 doctors or so many nurses. If they all go to the southeast, that doesn't really help us. And we do know that the north is under-doctored, if we just take doctors as one profession, compared with other parts of the country. And the same applies to physios or radiographers or what have you. Now, some of this is about recruiting locally, and often our nursing colleagues are recruited locally, but some of the other professionals actually do move across the country. And I think there is something about playing into the workforce discussions about fair shares, especially as our communities are often more deprived. And yet it's the inverse care law, isn't it? You know, the most deprived communities have less doctors and less physios, etc. So I just made that general point really to say that even if the government said there would be loads more professional staff, I think we need to make the case that the North and of course West Yorkshire has a particular claim on some of those.
Thank you. Rob?
Yeah, I don't know if Kate or Brendan want to comment on that from a people board perspective. I think there's a lot in what you've said, Linda, that's important for us to keep reinforcing.
Thanks, Rob. I'll come in. Hello, I'm Kate Sims. I'm the Director of People. I realised I didn't say that earlier on in the meeting. I think the points you make are really important, Linda. Possibly at the People Board, but I think more importantly in our regional discussions, we meet very regularly, as you'd expect, across the northern or our part of the northern region with the other ICBs, and certainly some of the conversations and representations through NHS England and colleagues who lead on the national workforce planning. We have all sorts of training, education, planning forums and meetings, and I think you'd expect it's at those that we are particularly making those representations as well. So we will continue to do so. Thank you.
I think the other thing to do, so there's a couple of other things that I'd just say at this point. So I can see Brodie on the screen, and you may have seen the case study from Leeds Community Healthcare that was published around hyperlocal recruitment using analogue techniques, which we're learning from right across the system. So if you leaflet households in an area, what that's showing is that you actually get some significant recruitment from people who would never think about working for you if something was just on NHS jobs. So we've got to pick up some of these novel things. If we look at the work we're doing on the Health and Care Academy in Wakefield, building on experiences from Leeds with local recruitment, that's another positive. Brendan and I were talking this morning about T-level students being given work experience and real jobs in the system whilst they're doing their qualifications. There are all sorts of things that we can do to improve the flow of people in. Critically, what we've got to recognise is that most of the staff that we will have in 5 years are the staff that are working for us today. And we've got to make this a context and an environment where people want to stay. And there's a huge amount we can do on that as leaders and as organisations in West Yorkshire without having to lobby national government. Sorry, Kate.
Sorry, it was just to add to that. It's probably worth saying, Rob, with the last comments you've just made, that we are having on Thursday a sort of a West Yorkshire system-wide look at retention. And we have a workshop which is very well attended from across the sectors. And I think there's a real question for all of us about what do we want to do at system-wide level around the retention agenda. And I think pick out some really core priorities which aren't just organisation or sector specific, but could make impact right across. I think you're absolutely right. I think the people that we've got here are clearly the people that we wish to retain. And I think that group going forward can be quite powerful in terms of some of the collective messages and indeed work across West Yorkshire. So that's a session that I'm chairing on Thursday for the West Yorkshire system.
Thanks. On the Hewitt review, I don't think we've had anything from the Department of Health and Social Care that is a meaningful response to the recommendations. So we've had a response from DHSC, which I think said that they will consider them in due course. What we do have next week is the NHS Confederation Conference, which is often used by the Secretary of State and by the Chief Executive of the NHS to set out their priorities for the coming period. And my hope is that there'll be an opportunity to bring some things together in a way that will make sense for everybody. So we've had the Messenger review, which set out 4 recommendations for how we should lead in systems. We've had the Hewitt review, which has set out how systems should operate in a context of a revised NHS England, which has its own operating model. And we've got some work around the NHS at 75, which I've reflected in my paper, which says what we might want to focus on in the medium term as we go forward. So I think at this point, Kathy, there might be an opportunity next week to hear more about how all of that fits together.
Could I ask Rob? I mean, obviously very good news about the capital announcements, and particularly about Airedale. We sometimes in this country don't perform brilliantly on delivering big projects on time. And could I just ask you to sort of outline a bit more what the sort of relative roles of the different parts of the system are in progressing these things, how far this rests with the local trust, what the role of the ICB might be, where there are potential blocks, and if there are issues where intervention and consideration by the partnership board would be relevant. Sorry, is that clear?
Yeah, sure. So
it's just occurred to me. Yeah.
So I think the first thing I'd say is we don't talk about the things that are successful. You know, we hear about, you know, so I would challenge your thing. We're not very good at, well, I think your suggestion that we don't always deliver capital projects to time and budget. Well, we've got Red Kite View open and successfully delivering care in a fantastic environment. I know that the trust I used to run spent £80 million on capital developments, major capital developments, which were on time and delivered improved environments for people with mental illness. We've got a whole raft of really good examples. I know that the new A&E at Huddersfield is progressing really well, using and delivering a really good social return. So let's make sure that we focus on some of those positives. But the reason we can do that is because we've got some expertise around some of these projects and good partners. So we need to have the right infrastructure and decision making to make sure that continues to be the approach. Now, as I understand it, and colleagues at Airedale may want to chip in here, you know, Airedale will be working closely with the National Hospitals Programme around the support that they will be provided with in terms of design, as well as in terms of procurement and delivery of the new hospital. That hospital will have to be supported by Bradford District and Craven as a place in terms of how it fits clinically, what's the clinical model, and does that fit with how all that's going to work. And the ICB will also be asked, does it support what's happening in that development? But there will be that national input through the future new hospitals programme, which may look and feel a bit different from what's gone before. Calderdale and Huddersfield isn't part of it, predates the programme. The mental health developments that I've described predate the programme. So there'll be some new elements of that which we haven't encountered before, and it's the same for the Leeds developments. But I don't know if Feluke or Andrew wanted to give any insights into the kind of conversations they've been having with the new hospitals programme and what decisions they'll want to be involved in.
Thank you, Rob. I think you've described it accurately. For those who don't know, Feluke Ajayi, Chief Executive at Airedale NHS Foundation Trust. So we are now part of the new hospitals programme and will be working with them in terms of the delivery of the new hospital. The approach that's being taken now for new hospitals is a model 2.0, as it's referred to hospitals. So there will be some things that are determined nationally that we will need to work to, and some central designs that are being developed in relation to that. But there will also be some things that will need to be done from a local perspective. So understanding the parameters locally, the environment in which we are working, and those sorts of things we will need to do. And there will be some bespoke things around enabling works. So, for example, on our hospital site, we do need a new energy centre. So that'll be one of the first things we'll be doing. Other hospitals may not need to do that. But as Rob has also said, we are in conversation across Bradford District and Craven with regard to our clinical model that will influence the shape and size of the hospital that meets the needs of the population across the wider place. And so those discussions are ongoing in terms of what we anticipate will be the future clinical strategy for the development of the hospital. The announcement gave a confirmation and commitment by the government that the new hospital will be built by 2030, and that's certainly what we want to achieve, given the what we have been advised by the independent engineers. So that will be what we're working to, but it's very early days and we're yet to have a first meeting yet with the new hospital programme following the announcement.
Thank you.
I can see it.
Thank you for looking. Just very Andrew, and I should perhaps say my initial question was probably a bit more convoluted than I intended it to be. I suppose what I'm really saying is the government approval we've got mean full speed ahead and everything's there, or are there kind of potential central blockages along the way and decision points that could still interfere with this? I think you've hinted at some of that, but hopefully not. This is more substantial than simply an announcement in a press release. It's a real commitment. Andrew, I think, do you want to come in as well?
Yeah, I think it's a really good question, Councillor Swift. I think just to add to it for clarity, the RAC-related risks haven't gone away, and we've got a continuing programme of remedial work to shore up the existing estate to keep it as feasible and open for business up until 2030 to coincide with that. Clearly, both the progress of the new hospital and any further changes in relation to the RAC-related risk and remedial programme, we will escalate through place and obviously through to the Partnership Board, continuing to keep a close dialogue with Rob and Kathy, which has given us the support to get to the place we've got to today.
Thank you. Okay, if there are no more questions on Rob's report, let's move on to item 6. And can I welcome Hannah Davis from Healthwatch Leeds? And Hannah, invite you to introduce this item.
Thanks, Councillor Swift. Yeah, my name's Hannah. I'm Chief Exec at Healthwatch Leeds, and I'm here on behalf of the 6 local Healthwatch working across West Yorkshire. And as always, it's really great to start our West Yorkshire meetings with people's experiences and really frame the discussion that we're going to be having around access to dentistry. But it's almost one of those issues that, in a way, I think many of the people sitting in this room or on this screen are aware of this issue in the roles that you play and working in local places and communities around the significant issues and impact that the issue around NHS dentistry is having on people and communities. It's now impossible to register now as with a practice as a new NHS patient. There's significant years of waiting lists, and increasingly we have more and more dentists going private, and the impact that has on people, particularly, it can be absolutely devastating and life-changing. And there is a huge inequalities lens to put across this. If you can afford to pay for NHS treatment, you can get treatment, but if you can't, you can't. A report that's been pulled together by one of my colleagues, Stacey Appleyard from Healthwatch Kirklees, is in the papers, and hopefully everyone's had opportunity to read that. We as Local Health Watch have been highlighting this as an issue, I think, since Local Health Watches have been in existence, and we've highlighted that both locally and nationally. And I think I think it's very positive, the approach that West Yorkshire are taking to this, on really understanding that this is a significant issue for the people of West Yorkshire and looking to find solutions around it. We did have an involvement session before the Integrated Care Board meeting around this, and it was great to have people with lived experience, but also lots of different ways to hear people's experiences, and one of those ways was via a video, so which I think Lauren's just going to play, which hopefully will give a really good framing of the experiences that people are having across West Yorkshire at the moment.
I tried to contact all the NHS dentists on the NHS Choices website in and around my area, but I was told the waiting lists are at 3 years upwards.
I have been on the waiting list for braces for 8 years and have still not had a response or heard back from my dental surgery. What would improve this? Regular communication with service users.
I was knocked off my road bike a week ago and went face first into a steel lamppost. I've knocked my upper front teeth out, chipped an upper canine tooth, and loosened most of my bottom teeth. I went to A&E and I was advised to find a dentist as soon as possible. I've had no luck. My regular dentist retired last year and I've been unable to register anywhere.
What I feel should change is the timescale for my daughter's treatment. It is disgraceful. The amount of pain she suffered was horrendous. It affected her attendance at school. She started having anxiety and she lost her friend group because of the absence.
So my husband has a fear of dentists, so he hasn't been in a long time, which means he no longer has a dentist, but is now experiencing pain in his back tooth.
Couldn't find an NHS dentist within my area. All seem to be willing to take on private patients or on a half and half type of patient basis.
Not able to get a dental appointment. When I'm an NHS patient and a filling had come out, I did not want to pay privately, as I was told I would then lose my NHS place. So I had to say that it hurt 8 weeks after putting in the temporary filling, which did not work. What would improve this? To be able to have 6 months or even yearly checkups. Dentists all seem to be going private. Cannot always get an appointment for vulnerable children. Also, the referral process could be quicker. There are simply no NHS dentists taking on patients, so I haven't had a dentist for 10 years. This has led to 3 emergency dental appointments over the last year and a tooth extraction due to an abscess, which could have been prevented with regular checkups. What would improve this? More NHS dentists. Easy access to NHS dentists for people with pre-existing chronic physical and mental health problems. I was given antibiotics from the walk-in clinic at a local hospital due to the pain I was experiencing. This alleviated the symptoms for a short period of time. However, a dentist has not seen me. I think I have abscesses in my face and my face still feels numb. I was told to see a dentist and I have called lots of different practices, but I've not been able to find anyone to see me.
I'm disabled and in a care home. I'm unable to get to the dentist, therefore my dental requirements are not being met. What I feel would help is home visits for the simpler procedures.
Don't know if you want to move straight on, Ian, or if you want to take any reflections, Councillor Swift.
Yeah, let's just see if anybody's got any queries or comments on the work and that's backed up. I suspect, to be honest, many of us very much recognise the situation that's described there. Yes, I'm seeing plenty of nods. So perhaps it is, so perhaps it makes sense to move on to the next item and merge the two together. And obviously, Hannah, feel free to come in if there's points about patient experience that contribute to that. But I'll ask Ian to introduce the paper and the report.
Yeah, thanks very much, Councillor Swift. So what we're doing is we're sharing with you a paper that we considered at the board of the ICB 2 or 3 weeks ago at our last meeting. And we're doing that reflecting the fact that the ICB took on delegated commissioning responsibility for pharmacy, optometry and dental services from April this year. We wouldn't normally bring a paper to the partnership board after we've discussed it at the ICB. We're making an exception for this, I think, for 2 reasons. The first, as you and Hannah have alluded to, is we've had a lot of conversations about dental in the last 4 years as part of the work that we've done in developing the strategy for the West Yorkshire Health and Care Partnership. And now that it's the responsibility of the ICB, we've probably got more opportunity to do something about it than we had in the past. That's the first reason. And the second reason is there's recommendations in here that go beyond the scope of the NHS. So there's recommendations in here around oral health and prevention, which we'd really like wider partnership support for. So I guess the context for this has been really well set by Hannah in the video that we've seen. There are huge challenges with dental services nationally and in West Yorkshire. They're a result of long-standing structural issues, national issues that are quite difficult to resolve locally, including a national contract, which most commentators would believe isn't fit for purpose in terms of what we're trying to achieve through dentistry. And I guess we're working within that context. What I've learned over the last few months is that there's quite a lot of good, promising practice already happening in West Yorkshire that we can build on. And if as a partnership we take a slightly different approach to this than NHS England had in the past, there are things that we can do to make an improvement. But I wouldn't want to sit here and promise that we can improve dental services across the board quickly, because I think that's clearly not something that's within our gift at this point. So the paper sets out 6 recommendations that were all agreed by the board of the ICB 3 weeks ago. The first one relates to oral health and prevention. This is a responsibility of local authorities. I think what we've shown in the paper is some really good practice happening across local authorities to engage with children, to engage with schools around oral health improvement and poor oral health prevention. I think there's an ask there that we work together as local authorities to share good practice, to scale things up where it makes sense to do so, and to really create a strong network of learning based on the work that we've already done and the evidence base that we've already got. The second thing around oral health and prevention is fluoridation. One of the things that you'll be aware of as a result of the Health and Social Care Act is the responsibilities around fluoridation change from local authorities to the Secretary of State. This should hopefully help overcome some of the challenges that have existed in the past around fluoridation. The way that water flows, it's not a decision that a single local authority can take. It's probably not a decision that a single ICB can take. We started exploratory conversations with our neighbouring ICBs around this, as well as with Department of Health, but we'd like support from the Partnership Board to progress those conversations. And then the third area around oral health and prevention is around data, really, and support to the national dental epidemiology survey that happens at the minute. I think we've only got 1 of 5 local authorities that currently contribute to that. The dental team are working with local authorities around how we can make it easier to be part of those surveys, but clearly having a good evidence base and good data in order to make good decisions is really important. So there's a set of recommendations on that. The other recommendations relate more to the kind of the NHS side of things, I think. So the second one is around taking a more flexible approach to contracting for dental services, general dental services. So as I've mentioned, the national contract is quite constraining in terms of the way it values activity and what dentists can do as a result of that. In West Yorkshire, we've already had some good practice, I think it's fair to say, where we've flexed 10% of the contract value and focused 10% of the contract value for about a quarter of the practices in West Yorkshire to support different population groups and to take a different approach to working with different population groups. And the second recommendation, which was supported, was to expand that, both in terms of the breadth of practices, but also in terms of the value of the contract that could be flexed so we can better meet needs locally rather than relying on a sort of a national contract. The third area where the board of the ICB took quite a bold position, I think it's fair to say, is around use of contractual underspend. So we never actually spend the dental budget in West Yorkshire in recent years because there hasn't been the capacity there to deliver that. And what's happened in the past when NHS England have been the commissioner of the service, the money's been drawn back into NHS England and has been lost to dental services locally. We reckon this year there's going to be about £4.5 million of underspend in addition to the £2 million that we already recycle to use in other dental services, and we got agreement from the board to develop plans to spend that £4.5 million early in the year so that we can get it spent well to support people who need care for this year. So those two things, flexible commissioning and really expanding those access schemes, really important, I think, in terms of helping to meet needs immediately. The fourth recommendation is a slightly more long-term one, which is around developing a workforce plan and a workforce strategy for dental. There isn't currently a national workforce plan or a West Yorkshire workforce plan, but we believe there's quite a lot we can do around retention, improving retention, changing skill mix, improving skill mix, and also international recruitment. So we've got agreement that Kate's team will work with NHS England, the universities and other partners to develop that plan over the coming months. And then the final two recommendations were important but slightly more small scale, which is the Yorkshire Humber team that commissions dental services is very small. It's about 8 or 9 people currently, and they think with another 6.5 people working across Yorkshire Humber, they can make a big difference in terms of pushing these schemes forward. And the board was agreed to pay its share of that, if you like, which is 2 and a bit whole-time equivalents to support the expansion of that team. And as Rob said, that's in the context of quite a significant running cost reduction on ICBs, which again, I think hopefully demonstrates our commitment to improving dental services in West Yorkshire. So as I've said, it feels like a package of recommendations that will make improvements. I've been really impressed by the conversations I've had with clinicians in West Yorkshire in terms of their ideas and commitment to improving things despite the really difficult context that they're working in. But I think a big part of the work we need to do as an ICB and a health and care partnership is how we influence national partners, particularly around the contractual changes that we believe would make a difference, both in terms of meeting population's need, but also in terms of improving job satisfaction for people who work in dentistry. So I'll pause there, Councillor Swift. I'm conscious we've only got 20 minutes for this item, but happy to open it up to comments and questions.
Thank you, Ian. So I think first of all, got Rebecca. Rebecca, can I come to you?
Thank you, Chair. Thank you. And thanks, Ian, for the report. It's really, I just want to really strongly welcome all the recommendations that you've made there. Really good depth of, tackling a really difficult issue, but there's all sorts there that we can really get behind. And I really support the use of finances creatively and positively. I think that's a really strong statement and something we should be doing, because we shouldn't be, ideally sending back 4 million is when we've got such a need. It's quite upsetting, isn't it, when you think about it? So really support you on that. I just wanted to make a point about fluoridisation, because it is a very, very contentious issue, and I support the approach that you're suggesting. And just to sort of flag up the potential for, significant time being taken up with, protests or public viewpoints about it, would they also go to the Secretary of State? Would they go national instead of being handled locally? Because, historically, I believe there's been quite significant sort of legal, procedural difficulties that places have found there, but very happy to support the fluoridisation agenda.
Thanks. Ian, do you want to pick that one up? Or?
Yeah, so my understanding is that the duty around consultation has moved to the Secretary of State as well. That's not to say that this won't be quite a long and contentious process. As you say, the lobby around fluoridation is significant. Fluoridation is significant, but from what I understand, and I'm not a public health expert, the evidence is really, really clear. And it's probably the single biggest thing we could do as a system to improve oral health in West Yorkshire. So it's probably a kind of something that's worth taking on, but I think we absolutely need to recognise the time it will take and the the controversy that are likely to come with some of those conversations.
Thanks, Ian. Therese?
Thank you, Chair. I just want to thank Ian and ICB colleagues for the leadership they've taken on this. I'm Chief Executive of Bradford District Care Trust, and we provide a specialist community dentist service. And it's just on the recommendations, which I do support, Ian, absolutely. But if I talk to my dentists, and we provide a service for people with learning disabilities, mental health, phobics, children. The frustration that they have is that they get people in, they get them dentally fit, as they call them, and then they send them out into NHS land. They can't pick up dentists, and then they bounce back into our services 2 years, 3 years, 4 years down the line. So in terms of the recommendations, I just wonder, I think it's probably implicit, but should we make it explicit around that vulnerability piece? So do we try and look at that vulnerability group? Absolutely, in terms of our first steps, because that will then release capacity from the people who are coming back into our service 2 years, 3 years down the line because they've lost their oral fitness. But I'm very grateful for the work, which I do keep talking about, as Ian knows.
Thank you. Brodie, and I'll come back to Ian.
Just a couple of points, really. Firstly, to say I thought it was also a good piece of work. Very much appreciated, Ian, and will certainly get us moving forward to important places. I wondered what your confidence level was on the money remaining available and the staff becoming available, the workforce issues. Are you okay with those? Because both of those look to be high risk areas.
I'm confident on the money and not on the staff, Brodie, if I'm honest. So I think the money's been confirmed by the ICB. We had that conversation with Jonathan Webb in the board meeting, and he's confident that we can use this money in this way. It's actually our money to spend on dental. It's just the system, the financial system before that meant that underspends were brought back into a wider NHS England pot. In terms of the workforce, clearly expanding the workforce significantly in that time period is going to be difficult. What we've got is we've got a set of practices that we know are delivering their full contract value, who with a bit of support and a bit of extra funding through extra access schemes could go beyond that, open up additional sessions and work with specific population groups to Rez's point to help meet those needs. We've got some good examples around schemes for homeless people in Leeds that there's an appetite to expand. So at the minute, what you'd be doing is you'd be working with the current workforce and asking it to work a bit harder. In parallel with that, we want to do the longer term piece around the workforce plan so that we can increase capacity. I mean, we'd like to be in a position ultimately where there's zero underspend because you've got the capacity there to deliver the full contract value. So this does feel like it's a bit of a short-term tactical response, but you know, we're confident we can spend that money well, and the work I've seen that Hayden's on the call, who's done a lot of the legwork behind this, is working with the Yorkshire and Humber team to do exactly that, work out how we spend the money well this year.
Thanks, Ian. I thought the preventative stuff was exciting, positive and helpful, and I think that'll make a big difference if we can get that moving fast. Okay, thanks.
Thanks, Rob.
Ian, do you want to say anything about the opportunity with the work that we're doing with the Department for Health and Social Care and the Policy Hub, and the opportunity that might bring around fluoridation?
Yeah, happy to. So I think we've mentioned the Policy Hub work here before. So essentially, we've got an arrangement, local partners in Leeds and West Yorkshire with the Department of Health and Social Care to work on the development and implementation of new policy to try and almost create the sort of the full policy cycle where we almost act as a kind of a test bed and a feedback loop for national development of national policy. We've had a couple of meetings on dental with the national team, and they're keen to work with us to understand what the issues are on the ground, and look at the sort of the policy levers that they could help with in terms of addressing some of those challenges. Fluoridation will be part of that conversation, Rob. The other things we're talking about is, you know, access to pension schemes for dental, non-dentist dental workforce, digital and joining up data systems for dental staff, and almost kind of trying to create more of parity between what happens in dental and what happens in other parts of the NHS. So those conversations are live. And as you say, there's an opportunity to influence there. The big thing around that is around the sort of the dental contract, and I think there's a bit of a thought as to whether we can use some of our experience around flexible commissioning to potentially try and influence the direction on that as well.
Thanks. Rob, did you want to come back on that?
Yeah, so the final thing I want to say, Chair, I think, apart from thanking Ian as well and Hayden and all the team for the work that's gone into this, because it is substantial. It's a really good piece of work, I think. I think we had a conversation in our development session, didn't we? And I remember Rebecca talking about, can we use this money flexibly? Let's find a way of doing that. I remember us talking about prioritising capacity in this area if we could, and all of those things now have made progress. So I think that's a really great example of us setting out, looking at a problem, being given the responsibility of addressing it and starting to develop a plan to address it. The thing I wanted to ask the partnership board was this point on fluoridation. So, as others have said, it's a contentious area where there's strong evidence that it has a substantial impact. We shouldn't shy away from contention where there are things where there's a demonstrable impact, would be my view. And I wondered whether the partnership board wanted to give its support for us to explicitly develop proposals for fluoridation in West Yorkshire.
Thanks, Rob. Certainly that was my reading of the recommendation here, and so the contributions I've heard so far are positive on that. But let's just test that one out fully. We explicit support further work on developing the case for fluoridation. I'm not seeing any views to the contrary on that. So yes, I think you can take that as a clear endorsement for that. And I've shared anecdotes before about the last time this was debated in Calderdale, being one of only 2 councillors who voted in favour of fluoridation. A long record of support on this one. Ian, you want to come back on things?
Yeah, it was just to pick up Teresa's important point around sort of the inequalities and vulnerable groups aspects of this, and we are absolutely prioritising that in the work we're doing. We're working with the consultants of public health in the Yorkshire Humber team, working with Sarah Smith in the ICB around how we can link it with the work that we're doing around Core 20+5, how we can link it with the work we're doing around ICS of Sanctuary, so we can really support communities who've got the greatest needs. So that's absolutely part of the discussion too.
Thanks. I had a bit of a related point, I think, which sort of comes out the example Therese gave about, working with groups and then finding you address their immediate problems, but it slips back because they still haven't got the access to ongoing dentistry. And that's just sort of understanding. I mean, a lot of the examples in the Health Watch video were about adults, and just understanding what the challenges are around children's access to NHS dentistry, because clearly the preventive work we might do through schools and public health really needs to be underpinned by them also having access to dentistry. I apologise if that's covered in the report. I missed it there, but I've got 2 hands. I've lost it.
Did you want me to come in on that one, Councillor?
Yeah, please. If you've.
Yeah, I mean it's similar. I think in terms of access to dentistry, and I think Teresa's point is unfortunately part of the reality that we're dealing with is that unless you've got routine, reasonable access to general dental services, you're going to have deterioration after treatment, and that's the sort of the longer term goal really through the work that we want to do around the contract and workforce, etc. So that's not going to be solved overnight. We know that children's oral health is a significant issue. It's a significant issue associated with more deprived communities, and that leads to significant demand for NHS services. So it's a really important part of the story, and access to general dental services for children is also challenging.
Thanks, Ian. Kathy?
Thank you. As chair of the ICB, I suppose I wanted to reflect on how I hope this is an example of how the ICB is demonstrating as the commissioner, one of our core roles, what we can do. And Ian's talked that through very well, particularly around flexibility and proactive investment. But something, as you know, Tim, that continually comes up in our partnership meetings and in ICB meetings and the discussions in between are the lobbying points. And something came up earlier that Linda shared on what can we do more on workforce and national policy. But coming together on fluoridation is a really big point for us all. And I suggest that that's a standing item going forward, as well as any prevention work, because that's the other point in the paper as well, a life course approach and a prevention approach. And I'd really welcome, I suppose, joint presentations, sharing of best practice across places, as well as between local government and NHS on any work that we're doing on prevention and sharing best practice. There are themes that come up at every meeting, but this seems to be a key point here. And the last point I wanted to make, which Ian has shared in his paper, is not only the reflections from the ICB board paper and the Commissioner's view, but also the viewpoints that we got through the Health Watch Insights, which we've talked already about today. Really practical things about freeing up times for routine appointments. There's a point there on oral health for children, and also joining up services. And so the example that's in the paper, as well as that we'd heard at our board session, was about someone going into A&E but being sent back to a dentist, but the services weren't connected and the person was left alone to try and sort it out and didn't know how to. So there are lots of messages there, but I wonder, Tim, whether we can bring more on the prevention and the good practice sharing at the partnership board, as well as then complementing it within the ICB board and from the commissioning and workforce side.
Yeah, certainly, and I think perhaps we can pick up when we next have a meeting of the council leaders and health and wellbeing chairs, just making sure that we are picking up and sharing back in place the public health and indeed children's services roles in supporting this work as well.
Tim, could I just come back on one other point? There's a number of requests, as you know, during the papers today on data and data sharing and collection as well. And I just wouldn't want to finish up on this item without Ian just putting a reminder out. And I know a colleague later under another item will put another reminder out about data, but how we consistently share data together, which I think then we're evidence-led, which is one of the things we want to do in West Yorkshire. So if that's okay, Tim, I just wanted to invite Ian on that point.
Yeah, thank you, Ian.
Yeah, so as I said, there's a national survey that takes place to build a picture of oral health in West Yorkshire, and I think based on last year, I think one of the 5 local authorities submitted to that, which means that we obviously don't have the evidence base to make some of those decisions about where to prioritise money. And when we've got £4.5 million to play with, that kind of becomes quite important in terms of how you want to spend it to best meet people's needs. I think there's a range of reasons why that has been difficult and quite complicated reasons. And Sandra Whiston, who's a consultant in public health who works in the dental team, is working with local authorities around how we can do that. I guess your leadership and your support behind, getting behind that survey in the future would be really helpful, I think, to support Sandra in those conversations.
Thanks, Ian. So just for clarity, that is data that the local authority or public health teams would provide.
Collect it. I think that's part of the challenge. It's a collection. It's a national survey.
Collective, yeah. They're a part of it, okay. Right.
But there's a cost associated with it, which is again part of the challenge.
Yeah. Okay, perhaps worth sharing. Yeah, making sure that that's shared with local authority reps. Yeah. Okay, thank you. So thank you very much, both Hannah and Ian, for that item. So I think it's been really useful and valuable discussions. Let's reiterate that we are strongly endorsing the work on making progress on developing the case for fluoridation, but also strongly endorsing that message about the importance of sharing that evidence base about practice and contributing to the data collection. Yeah, I'm not seeing any dissent from that, so thank you very much, everybody. Now, slightly unprecedented for this meeting, we've got to the point where it says comfort break ahead of time. So I suggest we take advantage of that, take a short break now. We will absolutely restart spot on the dot at 3 o'clock, because I know 10 minutes doesn't always quite give time for the kettle to boil. So we'll turn the live streaming off for the next few minutes, and we will restart promptly at 3 o'clock. Thank you very much, everyone.